Good evening, everybody. My name is Dr. Jafar Alsaid. I'm a nephrologist and I've been practicing clinical nephrology and hypertension for 20 years. I would like to thank the organizer who invited me to present this topic, COVID-19 and hypertension. What is the link? I'll be touching base on the introduction of the COVID and its link with hypertension. We'll just touch base on some updated COVID epidemiology. We'll talk also about the link between the hypertension and COVID regarding prevalence, risk factors, and we'll touch base on the one of the hot topics, which is the RAS inhibition, renin-angiotensin aldosterone system inhibition, and the link to the ACE2 receptors in COVID. And then we'll touch base on some links with the usage of the ACE inhibitors and the ARBs, and then we'll end up with conclusions. Over the past 1.5 years, the world have changed, and we had been having a different type of lives all over the world, different countries. Travels have stopped, busy airports have stopped, and countries have closed their borders. Also, the people are stranded in their home with basically streets empty. Many businesses went out of work, and many employers were basically sitting at home. The burden was mainly on the health care workers, and we saw all over the world massive engravements, not because of disasters or wars, but because of a virus. Over the development, the human development, there were many steps that put us in the current situation that we are living now. And we believe that COVID have created a fingerprint in human development that will last for a long time. Whatever had happened from in home, basically from lockdowns, country lockdowns, and home orders, and closure of airports and travel, the cases continue to increase. And this was basically the statistic from August last year, 2020. The total number of the cases by the Johns Hopkins, which is basically one of the reference for the COVID all over the world, the total number of the cases were 22,949,000, and the leading countries were US and Brazil and India. When I just reviewed the statistic the day before yesterday, the total number of the cases now are 151 million all over the world. And nowadays, everybody who's following the news, we know that India is the leading country in the cases and the surge that can happen. And yesterday, by itself, they announced that there was around 400 million people, 400,000 people who had been positive infected over only 24 hours. This curve shows the increase in the cases from past March 2020 until today. Whenever we see some dip down, we'll be glad that things will turn over and things will improve, but then there will be another surge. And currently there is around between 500 to 600 cases a day. This graph basically shows the progression over the time in multiple countries. And this graph goes back to August 2020. We can see the three leading countries, which are basically United States and Brazil and India. When we update this graph, and this is the current graph, which basically from May, from the 1st of May, 2 days ago, you can see the curve from India, how high it's steep. And as mentioned, last day alone, there was 400,000 cases positive COVID-19. COVID has affected many organs, and it affects many organs. It affects the lung mainly, but also it affects the brain, the heart, the kidney, the liver, the blood vessels, the bowels. And we will be focusing today mainly on the effect on the blood pressure. So where is the link between hypertension and cardiovascular disease and virus, which is basically mainly a respiratory virus? We'll touch base first on the prevalence of hypertension among patients having COVID. When preparing for this presentation, I just searched on the National Library of Medicine, and the amazing thing is that in August 2020, when you just click on COVID and add COVID and hypertension on the National Library of Medicine, you'll get 5,400 publication over a 1 year period. And when I did the same search on May, a couple of days back, imagine how much research came over 1.5 years. 23,329 publications just by putting COVID and hypertension. So this basically progression and this amount of data that was published over 1.5 years, this is probably the first time that the science and medicine have such interest and basically such focus on one topic, and where everybody in the world are working together trying to fight the disease and put the information together so that we will be able to save more lives. When we look at the comorbid conditions that have been published in multiple literatures, we can see that the age, diabetes, cardiovascular disease, and respiratory disease, obstructive lung disease, smoking, obesity, CKD, and then malignancy are among the common comorbid conditions that had been associated with severe cases of COVID and also with infection with COVID. When you look at the hypertension per se, it was reported that between 15 to 35% of the patients who have COVID are having hypertension. And there was some discussion that it's probably not a causal relation. We know that association in statistics doesn't mean that it's a cause of the disease or the infection of the disease. But there was some suggestion that basically these disease cases are more common among elderly patients, and the hypertension also is common in elderly patients. And also other comorbid conditions that are associated with hypertension, obesity, and chronic kidney disease. These could be confounders that basically have provided the atmosphere or the link between the high association of COVID and hypertension. So when you look at meta-analysis from the earlier studies from China, multiple studies in China with multiple samples, we can see if we compare the prevalence of multiple comorbid conditions, hypertension, diabetes, cardiovascular, and COPD, we can see that hypertension outweighs all of these comorbid conditions. So in other words, patients who have hypertension are the patients who are basically higher prone to have COVID disease. But as I mentioned, this is not a cause and effect, it's just an association. When you plot these graphs, you can see the difference between the orange-colored hypertension and all the other comorbid. 2 times, in some cases 3 times more than the usual other comorbid conditions, which were diabetes, cardiovascular, and COPD. And when we just try to summarize the total prevalence of all the comorbid conditions in all the meta-analysis and try to get the mean, the hypertension will be around 22.5% prevalent in cases of COVID-19 infection. While if we look at other comorbid conditions, 3% for basically COPD, 12% for diabetes, and only 12% for cardiovascular, and only 13% for diabetes. These are the references for the previous studies for whoever is interested. And when we look at different population other than China, so there were many publications, as stated earlier, from the United States, Italy, French, Korea. So we can see that this prevalence of high hypertension is not only unified to China, but it is basically present in all the other populations all over the world. That hypertensive patients are more prevalent, hypertension per se is more prevalent among patients who have COVID. And when you look at the hospitalized cases of COVID, so we are not talking about cases who are positive or negative having COVID, but we are talking about patients who are hospitalized for COVID. You can see that the hypertension is even higher in that population, around 53%, so almost double of the basically the previous prevalence. So that means that almost half, or even more than half of the hospitalized patients with COVID would have history of hypertension. And also it has been shown that the mortality of COVID is around 27% patient with ACE inhibitor, 33% patient with ARB, and whoever using any antihypertensive medication, it was around 39%. And about the severe cases of admission, cases who goes to ICU, the severe COVID cases which had respiratory failure, multisystem failure, and sepsis, and admission to the ICU, the prevalence of hypertension, one studies of around 1,382 patients, and showed that basically the admission to an ICU for a case of COVID, if the patient have hypertension, would increase 2.5 times more than the normal. So that means the hypertension add basically 2.5 times more possibility or probability to have the patient with COVID who is admitted to the hospital to get severe infection and require ICU admission. When you look at the other side of different types of presentations and different type of publications, it shows that actually there is another spectrum of presentation, and there's another point of view which showed that using ACE inhibitor or ARB were not associated at all with COVID infection, and also it was not associated with basically the prevalence of COVID infection or admission in the hospital, and also the calcium channel blocker have been shown to have basically a neutral effect on the infection with COVID or the severity of the disease. When you come at cases who patients who have kidney disease and have COVID, we look at the main presentation for these patients. We found that hypertension is one of the common presentation of these cases who have acute kidney injury or kidney injury secondary to COVID. So that's a different prospect of hypertension. We're not talking about patients who have already hypertension, but patients who develop high blood pressure and kidney problems secondary to COVID. So hypertension was also among the highest comorbid factors in these patients. Looking at the mortality, the fatal cases, patients who died from COVID, we can see that the cardiovascular risk in these patients, or the cardiovascular disease in these patients, is among the highest factors or the comorbid factor that diseases that was present in these patients. And when we specify looking at hypertension alone, we can find the same relation is present there with having hypertension, high blood pressure, higher than other comorbid conditions in cases with COVID. So we have basically a strong association between COVID infection per se and hypertension. We have a strong association between admission to a hospital and COVID. We have higher association, or one of the highest association among other comorbid conditions between hypertension and severe COVID and ICU admission, and now we are showing that there is also a higher association between mortality and cases that died from COVID and hypertension. When we look at the mortality and the difference between other comorbid conditions other than hypertension, we can notice the great difference between hypertension and 38% as compared to the other comorbid factors, which are the diabetes, cardiovascular, and COPD. So if we think as hypertension and COVID as a pulmonary disease, is there any link between hypertension and regular pneumonia, which is basically the community-acquired pneumonia? And when we look at the literature, there is actually an association between hypertension and pneumonia. The association basically, if we go back to the criteria or severity of pneumonia, which are basically identified by the curve 65, which requires an age. So an age above 65 is basically one of the indicators of having severe community-acquired pneumonia. Now we know, as mentioned earlier, that hypertension is more common as the age progresses. So the link is basically, most probably, is the older age, having higher prevalence of hypertension, and also these are the cases who will have severe community-acquired pneumonia. And also the outcome in these cases is not all the time good. So when an elderly patient gets pneumonia, his risk is much higher than a patient who's young and develops pneumonia. And now there was a lot of earlier argument between the use of ACE inhibitor, the use of ARB, and COVID. And when you look at the ACE ARB with an association of community-acquired pneumonia, you can see that there are some publications stated that using ACE and ARB have shown reduced risk of community-acquired pneumonia, actually. And this is, we're not talking about COVID, but we are talking about the regular community-acquired pneumonia. And also stated that basically the severity of the pneumonia would be less, and it's different from calcium channel blocker, which basically are neutral. So patients who are using ACE and ARB basically have less severe community-acquired pneumonia, and also it had been stated that they have lower mortality when they develop pneumonia. So we'll go back on the RAS system, and we'll spend the coming few minutes to elaborate on basically the link between the COVID and the RAS system. We know that the RAS system, the cascade ends with angiotensin 2, which is the potent, basically enzyme, and then it goes through this pathway leads to two tracks. Either the angiotensin 2 will be linked to the AT1 receptors, or it will be linked to the MAS and the AT2 receptors. If the cascade goes to the direction of the A2, AT1 receptor, then at that point it will cause the deleterious and the damaging effect from vasoconstriction, inflammation, fibrosis, and all the other inflammatory cascade with higher cardiovascular issues and cardiovascular disease. When the cascade is deviated toward the AT2 and the MAS receptors, this is basically a more favorable outcome, causing anti-inflammation, anti-fibrosis, vasodilation, and this is basically the protective part of the mechanism. So whether the cascade will be shifted to the AT1 or the cascade is shifted to the AT2, this will be basically the detrimental part and the outcome of activation of the RAS system. And it was shown that basically this cascade can be shifted with the ACE2 from angiotensin 1 to angiotensin 1-9 and from the angiotensin 2 to angiotensin 1-7 toward basically the vasodilatation and the AT2 receptor pathway. And when we look at actually at the link of COVID, we know that nowadays basically all of us know that COVID will be linked to the ACE2 receptors, causing downregulation of these ACE2 receptors. And the downregulation of the ACE2 receptors basically will leave the angiotensin 2 enzyme shifted toward the basically to the AT1 receptor and all the deleterious inflammatory and the fibrosis and the cardiovascular disease. So downregulation of these basically receptors, the ACE2 receptors, will shift the RAS inhibition toward the AT1 direction rather than the AT2. And when we look at basically the site of the action of the ACE inhibitors and the site of action of the ARB at the AT1 inhibition, these basically studies have shown that it will upregulate the usage of ACE inhibitor and ARB in patients will upregulate the ACE2 enzyme. And upregulation of the ACE2 basically receptors will cause a deviation toward the site which is the AT2 receptor and toward the MAS receptor, causing the antifibrotic vasodilatation rather than deleterious cardiovascular outcomes from the activation of the RAS system. So when we look at the distribution of the ACE in the body, we can say the ACE2 receptors, which is the site where the COVID will be entering attaching the cells and entering into the organs. We can see that these ACE2 receptors are present almost all over the body, the central nervous system, the lungs and the heart and the kidney, reproductive system, adipose tissue, the intestine, the liver and the blood vessel and the upper airway. So it's not only in the respiratory system or in the lungs, but it's present all over the body. And this basically cartoon would just elaborate what had been stated earlier. That's by downregulation of the ACE2 when the COVID virus gets attached to the ACE2 receptor, it will shift basically the RAS cascade toward the AT1 and causing more pro-inflammatory, more oxidation, and more vasoconstriction and cardiovascular outcome, leading to lung injury. Another mechanism of the damage is by proliferating of the virus itself inside the lung, causing the direct damage to the organs, whether they are lungs or if it goes to another other organs like the bowels or the liver, causing more damage at least. And this is basically another cartoon of showing the same concept. And at this basically cartoon will show the effect, the point where ARB will be basically inhibiting the AT1 and the ACE inhibitor inhibiting basically the conversion of angiotensin 1 to angiotensin 2. In both cases, the system will be shifted and deviated toward the MAS and AT2 receptors, leading to antioxidation, anti-inflammation, and basically vasodilatation rather than the deleterious cardiovascular outcome through the AT1 receptor. So these studies basically shows the link when the patient is using an ACE and ARB and the expression of the ACE2 receptors. Most of these studies, although some of them are neutral with no changes, but most of these studies show that there will be basically upregulating of the ACE2 receptors and ACE2 enzymes when the patient is on ACE inhibitor and ARB. what would happen if the patient is already using an ACE and ARB? And there was a question in the beginning of the infection and the beginning of the pandemic whether the patient should stop the ACE inhibitor or stop the ARB or continue using both ACE inhibitor and ARB. So basically, on the mortality aspect, the patient who are using ACE inhibitor or ARB showed that they would have a lower mortality when they have COVID as compared to the patient who are not using the ACE inhibitor and ARB. And as we know that the COVID basically will stimulate the inflammatory cascade and the interleukins in multiple aspects. And if we look at specifically at the inflammatory cascades and that's stimulated by the COVID, we can see that interleukin 2, interleukin 6, and interleukin 7, tumor necrosis factor, and the chemokines all will be stimulated when the patient develops COVID. And also the main one of the main cytokines which can cause the damage and the inflammation in these patients would be the possibly the interleukin 6. And these inflammatory mechanisms and these immune mechanisms with the cytokine storm and the inflammatory cascade are one of the deleterious effects that can lead to the poor outcome of severe cases of COVID with the involvement of multiple organ failure. So one of the studies that I would like to share had addressed very interesting questions, which basically is the core of our presentation. And I'll just summarize what this study has stated. So they had actually three questions. The first question, whether the patient who are whether using ACE and ARB would increase the possibility of acquiring COVID infection. So patients who have already been on ACE and ARB, whether the susceptibility to get the infection will be higher or not, this is the first question. The second question, whether the patient who are using ACE and ARB and get COVID will get the more severe form of the illness. And the third question was whether if we add ACE and ARB on patients who have COVID, would that change the outcome of the disease into negative or positive outcome? So the answer for the first part of the question, when the patient is on ACE inhibitor or ARB, whether they are highly susceptible to get COVID or not, and actually the answer was no. So there was no association. But this is specifically for cases who are studied in hospital, not for the cases who are asymptomatic and mild cases who are not hospitalized, because these cases were not included in studies. The study basically included hospitalized patients. So the specific answer is patients using ACE and ARB, and when they have moderate or severe cases, the susceptibility to get COVID has not increased. But we don't know the answer for the mild and asymptomatic cases. And this is basically is the odd of having severe illness of COVID on patients who have ACE and ARB. And most of these studies from meta-analysis in multiple basic cohort, all of them showed that there was no association between the severity of COVID and the usage of ACE and ARB. So in other words, patients who are using ACE and ARB for whatever reason, whether it is hypertension or whether it's heart failure or ischemic heart disease, they would not, if they got COVID infection, the usage of ACE and ARB will not predispose to severe illness or severe COVID cases. And these are basically the references of the previous studies for whoever is interested. So the other part is the question whether patients who develops COVID and get infected with COVID and they are not using ACE and ARB, whether when we add these agents, would there be any change in the outcome of the disease? And the answer is still pending because there are studies that are still on the way, and there is one study from Ireland basically looking at this question, whether adding ACE and ARB would be beneficious or it will be deleterious and damaging in cases when we add it to patients who are using, who have already come. So we have to wait for the answers for these trials, which are ongoing, studying the relation basically more specifically in a prospective pattern rather than retrospective observational pattern. So the bottom line is that there is no association between having the COVID infection and the usage of ACE and ARB, and there is no link between basically the severity of the disease. And taking in consideration the higher and the most beneficial effect of using the RAS inhibition in patients who specifically have hypertension, heart failure, or CKD, or proteinuria, the benefit outweighs any doubt. And basically, the conclusion from many of the studies is that there was no negative effect of using ACE and ARB, and it should never be stopped in these patients. So the question that stated that we have to stop ACE and ARB on these patients doesn't have any justification, and we will be basically doing more harm to these patients. And these are some of the other prospective studies which will be waiting for the results to address the answer in more specific pattern in a prospective randomized controlled trial. So this slide actually summarizes all the recommendations from multiple societies all over the world, stating that ACE and ARB should not be stopped on patients who had COVID infection. On the contrary, they are encouraging to continue using these drugs, and the association was basically positive. That means less severe diseases had been reported in cases or in patients who are using ACE and ARB. So I'll just touch base on just the aspects or the basis of the treatments that is ongoing and under trials for COVID. And you can see most of them are linked in a way or another to the RAS system and indirectly to hypertension. So whether it is ACE2 analog, whether it's the NGO1/7 analog, or the G protein for the NGO1/4, or the MAS receptors agonist. So all the treatment hypotheses or the possibilities of having a drug to treat COVID is linked in a way or another with the RAS system. So as a final conclusion, I hope that I was able to show you the link between hypertension and COVID, and I hope I was able to show you that basically the RAS inhibition is the main cause, and the ACE2 receptors are basically the receptors that links the hypertension to the COVID. And the statement or the previous concept about the ACE inhibitors or the ARB and the deleterious effect in patients who have COVID, that doesn't hold any truth. So patients who are using these agents should continue using them, and if the patient requires to use them or we have to add them in patient with strong justification, there shouldn't be any basically determinant or any thing against using these drugs. On the contrary, when it's indicated, they should be used. And in the end, I'd like to thank you again, and I hope that we could find at some point, something good in the COVID infection. And as we said, everything has two aspects, one good and one bad. So what would be the good part of the COVID-19 infection? This is a question I would like to leave it for the audiences. And thank you very much.
I think this lecture includes two arms. The first arm about some studies or statistical information. The second arm, I think the Dr. Jafar highlighted the effect of ACE inhibitor and ARBs on the COVID and on the treatment of this infectious disease. The net result, I think, from this lecture that we don't stop the ARBs or ACE inhibitor if the patient under using of this drug, and we avoid giving this drug in severe or moderate cases of COVID infection.
تعليق بسيط بس حضرتك عشان انا هقول بس تعليق بسيط على المحاضره. طبعا انا كنت اتمنى اشوف هل في لينك بين ان يكون في نيو هايبرتنشن عند الكوفيد ولا ما فيش، لكن اعتقد ان فروم دي بيزكس ممكن العيانين اللي هم نوت هايبرتنسيف يحصل لهم هايبرتنشن او حتى باروكسيزمال هايبرتنشن نتيجه لاكيوت كدني انجري في العيانين دول، ان ده سيستميك ديزيز، واحيانا بيحصل فعلا ليهم اكيوت كدني انجري ويحصل هايبرتنشن. الحاجه الثانيه المايكرو فاسكولاتشرز بتتاثر في العيانين دول، ودي ايضا احدى الاسباب اللي ممكن تبريديسبوز لهايبرتنشن. نقطه ثانيه مهمه جدا وديت انا شفتها وقريت عنها وبحثت فيها، قريت في على النت فيها، اني شفتها بيرسونالي في بعض العيانين، عيانين هايبرتنسيف ورابيدلي ديتيريوريت ودخلوا في هارت فيلير not due to chest infection، ولكن لما قريت فيها كويس جدا لقيت one important issue في الناس دولت اللي هم بيحصل لهم endothelial dysfunction. وبعد لدرجه الناس عملوا اسسمنت انفيسيف اسسمنت العيانين دول بالكوروني فلو ريزيرف، لقوا ماركتلي ديكريز كوروني فلو ريزيرف وزود اسوسكوتيك في ناس سنهم 17 ل 25 سنه، وكان اتحول العيان لاكيوت هارت فيلر وهو هايبرتنشن. فاعتقد كان المفروض في المحاضره دي يتقال حاجه زي كده يعني.